We'll be presenting the history of the next case. The next case is a 28-year-old female, para 1 living one, with previous LSCS, presented with irregular cycles and intermenstrual spotting since 3 months, along with secondary infertility. No comorbidities.
No.
USG showed multiloculated uterine niche of the with a residual myometrial thickness of 1.9 centimeter, depth of 7.7 mm and a width of 1 centimeter and gross PCOD. She is posted for laparoscopic isthmocele repair by Dr. Nitin Shah, sir.
Yes, sir. Yes, sir.
Yeah, so this is a good case of the isthmocele, previous history of cesarean section. Let's evaluate with the hysteroscope first. Whether
Yes, sir.
we will correct hysteroscopically or laparoscopically.
Yes, sir.
The criteria is if the residual myometrial thickness is less than 3 millimeter, the chances of uterine rupture is very high. But here the residual myometrial thickness is 1.9 centimeter. That is quite good.
Good.
So let's see, because by doing hysteroscopic correction, we will be cutting the lower ridge using the resectoscope. Okay. So you are weakening the already weakened scar and you are widening the gap. So that is the only trick. If the patient is desirous of fertility, then whether to go for laparoscopy or hysteroscopic correction is still a challenge. So let's see from below what it is. And then we'll take a call whether to go for laparoscopic correction or hysteroscopic resection of the ridge.
Hello, Nitin sir.
Yes.
Are there any tips to prevent the incidence or the severity of isthmocele?
Sir, basically, whenever we do cesarean section, we should not go very, very low into the cervix. Most often it happens when the section is done on the full dilated cervix. We tend to go very much lower than the lower segment, and the incision is actually at the cervix. At that time, the healing is impaired because of the cervical glands, and there is a lot of isthmocele formation. Second theory is retroverted uterus.
Okay.
So if the uterus is retroverted, you may develop an anterior adhesion at the level of isthmus and leading to isthmocele formation. Yeah, बैठना ही Rashid.
So doing two-layer closure, does it prevent isthmocele?
Now there are a lot of concepts coming of continuous non-interlocking rather than continuous locking sutures, single versus double layer suturing, suboptimal healing or a microhematoma at the caesarean site.
Yeah.
These are the few causes of isthmocele formation. So whenever there are a lot of theory, there is difficult to pinpoint one cause of the isthmocele.
Fine.
Hold this. Can we have water? NS. The line. Air out. So we'll do a diagnostic scopy first, and then we will evaluate whether this will require a hysteroscopic correction or a laparoscopic.
The machine. It's okay, no? It's what is there? Yeah, fine.
Meanwhile, Sudha ma'am is getting ready. Can we shift to Nitin sir's OT?
Picture?
Shifted. Hello. Yeah,
Hello.
am I audible?
Yes, sir.
Yeah. So this is a hysteroscopy. We went inside. Okay. And you wait for sometime, open the outflow. Your water will get clear and you will get the feel. This is the left ostia. You rotate the cable on the opposite. This is the right ostia. You just come out by keeping the cable in downwards position. You come out, and you can see there's recess. Okay, that's the caesarean section level. Can you see caesarean is almost bang at the cervix rather than at the lower segment? Okay.
Yes, sir.
So that's sometimes the cause of the isthmocele when you do caesarean full dilatation and you try to go lower down. You inwardly just cutting the cervical part, upper cervical part. Okay. So now looks like the residual myometrial thickness is very good. So we might just cut this lower ridge. What you can see, can you appreciate this ridge?
Yes.
Okay, so with the help of the resectoscope, we might just cut this ridge and fulgurate this vessel which is inside the isthmocele. Okay, and then give her a chance because there is some USG showing a fluid collection at this level. Okay, so we will just correct this in a moment. So I'll change to the resectoscope. Give me one moment and then we'll be back.
Audio visual, please shift to the other OT.
पानी बंद किया?
Hello.
Make the tube free, please. No.
Sudha madam, we are with you.
See, I need free movement, na? No, that's okay. Now, CO2 बंद करो. CO2 बंद करना. CO2 बंद कर दो. It's fine. Light inside, please. Sorry, everybody's way of working is different. CO2 बंद है.
Hello, is audio with Dr. Nitin Shah, sir? No.
Hello, am I audible?
Yes, sir. Is it always hysteroscopic resection is a mandatory, or we can directly go ahead with the lap excision?
Audio is with me or Sudha madam?
Hello. Hello, sir.
With you only, sir.
Okay. Sorry.
Hello.
Sorry. What was the question, madam?
No, is always a hysteroscopic resection is mandatory, or can we do it with a laparoscopy also?
See, all depends on the patient desirous of fertility. Patient is desirous of fertility and residual myometrial thickness above the isthmocele is less than 3 millimeter. The only route which is preferred is laparoscopy.
Laparoscopy. Yes,
Okay. Now, in this case, the residual myometrial thickness is 1.9 centimeter,
yes,
which
sir.
is quite good. So, what is my plan is, we will just go and we'll just resect the lower ridge.
Yes, sir.
Okay. Otherwise, the choice is definitely a laparoscopy when the patient is desirous of fertility. Just give me one moment. I got 26 French resectoscope, which is quite thick.
Yes,
So,
sir.
I think I need to do some dilatation. Okay.
Yes,
Otherwise, if I would have got the dilator by the lower one, because I use 26 French, but this is now. चलो हो गया. Done. Bana this also. This is.
Nitin sir. Nitin sir.
Yeah.
So do you use routinely misoprostol for if the
No, none of my procedure I use misoprostol. For a simple reason, if you are doing a submucous fibroid, there is a foreign body inside the uterine cavity. Uterus is constantly trying to push it out. Okay?
Yes,
So,
sir.
whenever you have a submucous fibroid or an intrauterine pathology, you will always find the cervix is soft and spatulous. So, you don't require to put a misoprostol. Vision is not good here. Pressure नहीं है पानी का.
What is the pressure you are planning to use, sir? Here?
I am planning routine
100?
100, 100, 150. Close this and इसको pressure दे दो ना. इसका तो नहीं आ रहा है कुछ.
and you're using a endomat.
Yeah. But there is some malfunctioning with the endomat. It's not. I'm not getting proper flow only. There is no fluid which is coming from the sheath. Flow ही नहीं है. Stars people, no flow. Where is the flow? कैसे होगा इसका मसल रिपेयर? इधर है नहीं है. एक काम करो वो निकाल दो डायरेक्ट ट्यूबिंग दे दो. डायरेक्ट लगाते हैं अपन. Anyway, we'll be using pressure bag and see because here definitely it's not there. The pressure is not developing. नहीं.
Sir, madam has started the procedure.
Yeah, please go and come
Can we
back.
shift?
Meanwhile, I'll just adjust the setting.
Hello, ma'am. Hello.
Yeah, you can. But still, I'm not happy with the way outflow is getting water. Not pinch, just block the cervical canal. Hold this tight. Not entering the cavity because स्टॉर्स का टेलीस्कोप भी है उसके साथ क्योंकि इसमें तो विजन ही नहीं है आउटफ्लो तो बहुत स्पीड में ओपन हो जा रहा है वी आर इन We are in now. Vision is not there. Vision कर दो अंदर एंटर हो गया लग रहा है सी आई एम गोइंग स्मूथली इन एंड आउट आई एम इन द कैविटी क्लियर ही नहीं हो रहा सी द वाटर इज सो क्लियर वाटर इज नॉट गोइंग इन अभी आया थोड़ा अभी थोड़ा दिख रहा है बट पानी किधर है पानी नहीं है अभी
Now we will shift the audio to Dr. Nitin.
Yes, Dr. Nitin, welcome.
Hello,
Yeah.
am I audible?
Yeah, you are audible.
So, hope you have seen I have coagulated the entire isthmocele with the bipolar saline resectoscope using coagulation current, and we have removed that lower ridge. Can you see this lower ridge is already cut using the bipolar cut current? Okay. So this we have corrected the isthmocele, so there won't be any fluid collection here. Okay. So that's the end from my OT. Thank you.
Thank you.